Our social protection for health, what are the health policy and systems research priorities? I'm Zubin Shroff, Technical Officer at the Alliance for Health Policy and Systems Research based at WHO Geneva. And with me here are three distinguished panelists. The presentation today will be made by Professor Sarah Bennett from the Johns Hopkins Bloomberg School of Public Health. Sarah is Professor and Associate Chair in the International Health Department and Director of the Health Systems Program at the Johns Hopkins School of Public Health. She's broadly interested in health systems in low and middle income countries, having studied issues of health financing, health markets, health worker motivation, and effects of development assistance on health systems. And she has a strong commitment to bridging research and practice, having served as Chair of Health Systems Global, as well as Director of the Alliance for Health Policy and Systems Research. Moving on, we have also with us Dr. Marco Stampini, Social Protection Lead Specialist from the Inter-American Development Bank, who has over 15 years of experience in the analysis of poverty, social protection programs, labor markets, and migration. He has a PhD in economics from the Santa Ana School of Advanced Studies, PISA, and has been a visiting fellow at the economics department at Harvard University. He has been at the IADB since 2011, where he manages the development of strategies on social protection, has carried out policy dialogues in a number of Latin American countries related to social protection, and has co-led and designed impact evaluations in Venezuela and Jamaica. He has also served as a team lead for social protection policy loans in Barbados, Colombia, and the Dominican Republic, among other countries. Finally, we have with us Dr. Mark Fletcher, Chief Director, Health and Social Development, National Treasury, South Africa. His academic qualifications include a 4-year specialist degree in community health and a PhD in health economics. He supervises a team of 10 at the National Treasury and has previously worked in policy and planning and health economics in the public sector. He has over 35 publications in the field of public health and health economics, and his work includes national health insurance research and development, putting in place health conditional grants like the HIV/AIDS grant, and heading health sectors and social protection function committees, which makes recommendations on sectoral budget allocations. Could I have the next slide, please? So, could I have the next slide after this as well? So just some ground rules to enable participation in the webinar. First, it would be great, as Jeff mentioned, if all the participants are on mute. We encourage you to type questions and comments using the chat box on the right side of your screen. And I will be then reading out the questions at the time of the question answer session. And we encourage you to tweet throughout the webinar, and you can see the Twitter handles of all the people associated with this work. Could I have the next slide, please? So a brief overview. I've just provided some introductions, and I will now go on to provide an overview of the Alliance for HPSR and why the Alliance is engaged in this work. Then Sarah Bennett will take over and provide an overview of the actual exercise to identify and prioritize research questions on social protection for health. We'll then have our two discussants reflect on the presentation and areas that they see important for research linking social protection and health systems from the perspective of policy and decision making, and I will be facilitating that discussion. We'll then open it to the audience to participate, and we encourage questions and comments. I will be, the questions you type in the chat box, I will be then reading these out, and it'll be no such a fast webinar. It's easier to have it done like that rather than try to mute and unmute each participant. So just keep providing your questions, and your questions will then be put to the panelists to discuss. Could I have the next slide, please? So just a brief background about the Alliance for Health Policy and Systems Research. The Alliance for Health Policy and Systems Research, established in 1999, is an international collaboration hosted within WHO Geneva that aims to improve health and strengthen health systems in low and middle income countries through increasing the generation and use of evidence for health system strengthening. And it does this through a range of objectives. There are 4 strategic objectives the Alliance currently has, including providing a unique forum for the health policy and systems research community, so stimulating the generation of new knowledge, particularly in understudied research areas, through increasing the demand for and use of this knowledge for health system strengthening, and Recognizing the need for capacity strengthening in this area, we work to strengthen the capacity for both the conduct and uptake of health policy and systems research towards strengthening health systems. And we seek to generate new knowledge in understudied research areas, particularly in line with the priorities of decision makers and researchers. And for decision makers in particular, this is important because unless the research questions are informed by their experience and relevant to them, it's more challenging to actually have this research inform policy. And priority setting exercises have typically accompanied a lot of the alliance's knowledge generation. There was a whole program of work on access to medicines, which was informed by a rigorous priority setting exercise. Similarly, we have recently released a journal supplement in the International Journal of Equity Health on the role of non-state providers towards universal health coverage. And this research program too was informed by a priority setting exercise, which actually helped to identify the research questions that were then developed into research projects and proposals through an open call for research. And in addition to helping to target funding and align funding, it's also the other rationale for this and for going through these priority setting exercises is to encourage and stimulate dialogue between policymakers and researchers regarding research priorities, as well as the development of innovative processes to actually undertake priority setting. Could I have the next slide, please? So in line with this background and history of priority setting to inform new knowledge generation, in June 2016, the Alliance issued a call for research for identifying research priorities related to the Sustainable Development Goals, with a view that these would be useful to HPSR researchers wanting to understand research gaps, for policymakers working towards the Sustainable Development Goals, as well as for funders looking to invest in health policy and systems research priorities. And 13 proposals were received, and based on a review process, the team led by Professor Sarah Bennett was selected to carry out this work. And 3 broad areas within the SDGs were identified, which would be the subject of in-depth research identifying the priorities. These included social accountability, multi-sectoral collaboration, and social protection. And previous webinars have focused on the first 2 areas. Just last week, we had a webinar to discuss work around multi-sectoral collaboration. And today's webinar will discuss the third thematic area, namely social protection. And with this, I hand over to Sarah to make the presentation.
Thank you very much indeed, Zubin, and good morning, good evening, good afternoon to everyone on the line. It's a pleasure to be here and to have this opportunity to speak with you about this piece of work that we did for the Alliance for Health Policy and Systems Research. Let me just see if I can forward the slides. Yeah. So much of what I'm going to say today has actually already been written up and published in this paper, and you can see the URL with the link to the paper here. And I believe that both of my colleagues, Mary Q and Nazreen Jassani, who collaborated with us on this piece of work, are also online. Mary is currently in rural Tanzania, and therefore we didn't think that she was well placed to lead this webinar today. But if you're interested in getting more of the background details about the work, and then please don't hesitate to follow up on the link here. So I wanted to start out a little bit by trying to position the work that we did in the broader context of the sustainable goals and sustainable development goals, and to perhaps try and explain why we decided to focus on this intersection between social protection and health. And obviously, when we were asked by the Alliance to think about health policy and systems research priorities linked to the SDGs, that's potentially a huge canvas. There are so many different goals and then different targets within the different goals. But I think that social protection, and particularly ending poverty, as you can see from the way SDG 1 is framed, end poverty in all its forms everywhere, is really very central to what the SDGs are trying to do. And then within that first SDG, target 1.3 is explicitly focused on social protection and talks about implementing nationally appropriate social protection systems and measures for all. Within SDG, which is the SDG obviously concerned about health and well-being, Target 3.8 talks about achieving universal health coverage, including financial risk protection. And some of you who may have been following the debate at the time will probably recollect that this target around UHC was really seen as being perhaps the primary target out of the many targets under SDG 3. So I guess, this focus got us thinking about how do these two different goals connect? And whilst we've clearly done a lot of work thinking about social health insurance and specifically about UHC, how do health systems connect to broader systems of social protection? Social protection can be framed in a number of different ways, but the way that we thought about it was addressing or encompassing these three different domains. Firstly, labour market intervention, so the kind of rules and regulations that can be put into place in labour markets, and some of these, as you can see from the examples here, have very direct connections to health. So, for example, requiring maternity leave or ensuring that employees have sickness leave obviously links very clearly to health and health effects. Secondly, social protection encompasses social insurance. And as I've already said, I think within the health sector, we talk a lot about social health insurance, and that has very clear links to social protection. But there are also other forms of social insurance, such as disability insurance or pension schemes, which may also affect health, affect people's well-being when they are sick. And then finally, social protection is said to encompass social safety nets. So when people do, for example, lose their jobs or end up as very low income, the social safety nets are able to at least cushion them from the most severe adverse consequences. And social safety nets may take multiple forms. They can include cash benefits, they can include food vouchers or food for work. They may include sort of interventions such as the development of homeless shelters. So this, broadly speaking, is how we were thinking about social protection. And I think that we can then see a number of different interconnections between health and social protection. So social protection can, for example, protect against risks that lead to financial and other vulnerabilities, including health vulnerabilities. So we know from the literature that people who are low income or below the poverty line generally tend to have much greater risk of ill health than those who are more affluent. And the role of social protection can help protect against low income and accordingly against financial risks. Social protection, and perhaps this is more directly linked to health systems, can also facilitate and or incentivize the utilization of healthcare services. And this is perhaps most evident when we're thinking about conditional cash transfers, which may make the receipt of cash transfers conditional upon use of particular priority health services. But there are also other ways in which social protection can facilitate the use of health services. For something as simple as making cash transfers available increases people's income, increases people's ability to pay for transport to health care, or increases people's ability to pay user fees for health services if they need to. Thirdly, social protection can provide goods and services that are complementary to healthcare. So I think one good example of this is that for people who are HIV positive and on antiretrovirals, we know that their ability to absorb and respond to those drugs is influenced by their nutritional status. So social protection may be able to provide food that complements the inputs coming from the health sector in terms of drugs. Then finally, social protection may provide practical and logistical inputs which are relevant to health systems. So for example, particularly in high or maybe upper middle income countries, there may be caseworkers who, for example, are working with people with disabilities who have multiple needs, both health needs as well as educational needs and social protection needs. So a caseworker would have the responsibility of making sure that the different sectors come together to coordinate the services to respond to that particular individual's needs. In different contexts, we're seeing linkages between social protection and health in terms of identity cards or perhaps being able to assess people's income. For example, I think there's a lot of interest in India in how identity cards can be used to indicate which people are below poverty line and therefore may have preferential access to different forms of social health insurance. So this slide just sort of captures the fact that there are many and quite different ways in which systems for social protection and the health system may be linked. So I'm coming more specifically to the piece of work that we did here, and this is really general across the 3 different domains in which we worked. What we were really aiming to do was to identify health policy and systems research priorities linked to the Sustainable Development Goals. And in particular, what I'm going to be talking about today is obviously about social protection and health systems. We wanted this work to be internationally relevant. That was part of the mandate from the Alliance, but also to have a particular focus on the situation in low and middle income countries, again, as that's the particular mandate of the Alliance. Thirdly, in terms of setting research priorities, the Alliance was clear that they wanted this to incorporate the perspective of policymakers, the users of the research, and not just our researchers. And finally, as has already been discussed, this was part of a broader exercise that also covered multi-sectoral collaboration for health and participatory and accountable institutions. So in terms of the methods or the approach that we used for this work, there were 3 main phases. We started with an overview of reviews. Actually, we started out by searching broadly in the literature on social protection and realized that there were a large number of reviews that had been done about social protection and health. And so we focused on those. So we looked at the existing literature first. We then supplemented this with consultations with policymakers, and I will talk in more depth about who we consulted and how we did this. And then we brought together these sort of 2 independent streams, what was already in the literature, together with policymaker views about what were research priorities in the domain of social protection and health. And we identified from this a number of potential priority research questions, which we then took to a 3rd phase, which involved researchers in refining those priorities and ranking them to develop a final list of what were felt to be the highest priority research questions. So I'm going to talk about each of those different phases relatively briefly, and starting with the first phase, which included the overview of reviews. So we developed with an informationist at Johns Hopkins search terms that looked at social protection, health systems, and the connections between the 2. And we restricted our search to low and middle income country articles which at least included low and middle income countries. We started out with over 6,000 records, and based upon this decided to limit our review to an overview of reviews, and this reduced the number of papers that we were looking at to 34 articles. However, I think it should be noted that the majority of the reviews that we were drawing on were really reviews that addressed cash transfers or had cash transfers as one amongst the interventions they looked at. So 31 out of 34 reviews addressed cash transfers. 4 out of 34 looked at food and nutrition, such as food aid. Just 1 of these reviews considered parental leave, and 3 out of the 34 reviews addressed other interventions. But these interventions were just single interventions. So the literature, I guess, is predominantly around cash transfers. In terms of the key health domains covered, a large majority of the papers that we looked at were around maternal, neonatal, and child health. So about 15 out of the 34 had a focus around MNCH. 4 looked at people living with HIV, and 4 had a specific focus on low-income households. Otherwise, we really found a scattering of health domains considered, from adolescence to mental health, disability, tuberculosis. Based upon these overview of reviews, we went through and we extracted information about the papers, but we also extracted information in terms of what the authors said about the priority research questions based upon the review that they had done. And I've listed here just the top 5 research questions that came out of this process. So the first most commonly mentioned research question concerned the pathways through which social protection programs affected clinical and non-clinical outcomes, and what were the implications of this for program design. The second most commonly identified research question concerned the effect of conditional cash transfer programs on healthcare quality, coverage and outcomes across different settings in low and middle income countries. And then thirdly was about the effects of unconditional cash transfer programs on healthcare quality, coverage and outcomes. I guess acknowledging the fact that their literature around unconditional cash transfer programs was significantly smaller than that around conditional cash transfer programs. There was then interest around the relative cost effectiveness of conditional cash transfer programs, in particular comparing CCT programs with other types of demand-side interventions. And then finally, at number 5, we get to a focus which is really unrelated to cash transfer programs and was really more focused about food aid and how the source, amount, frequency, mode of recipients, etc. for food aid programs affected intended health-related outcomes. So moving on, the second part of this work then involved interviews, in-depth interviews and focus group discussions with senior policymakers, including government officials and leaders from bi and multilateral organizations and NGOs. In total, we invited 85 different respondents to participate in in-depth interviews, out of which 54 did so. And just to explain the process here, we piggybacked to a great extent on international meetings where we knew policymakers would be attending. So this included the Global Symposium on Health Systems Research in Vancouver and also the Prince Mahidol Awards Conference in Bangkok. And then we supplemented that by more focused sort of searches for policymakers in contexts which we hadn't covered very well from those different conferences, and also using the network of collaborators working on this research to identify additional respondents. In the Middle Eastern region, we worked with a colleague there, Fadi El-Jadali, who pursued these consultations with policymakers primarily through focus groups, as you can see listed here. And we had 5 out of 6 of the WHO regions represented, with all of the regions except WHO Euro participating. I think that the commonly, in terms of the analyses here, we took detailed notes from these policymaker interviews. We also recorded them where we could. We didn't transcribe them fully, but we used that as a sort of aid memoir to go back and listen to what people had said. And based upon those interviews, again, we extracted the kind of topics that policymakers were interested in, and we converted this into research questions. So we didn't ask them directly, what do you think are priority research questions? Instead, we asked them about the kind of policy and practice changes that they envisaged in their country and the kind of evidence needs that they had to support those. And you can see listed on this slide the most commonly identified research questions from this process. I would note that they are completely different from what you saw on the previous slide. I think there's essentially no overlap between the kind of the top 5 questions identified by policymakers vis-a-vis what came out of the overview of reviews. Most commonly, policymakers talked about how routine information systems could best be strengthened so as to monitor and evaluate systems of social protection for health. Secondly, they were very interested in how social protection initiatives or systems could better be integrated or harmonized across different sectors. They recognized the need for more joined-up approaches to working on protecting the most vulnerable and felt that there needed to be greater harmonization across sectors. And thirdly, they were interested in tools and systems to assess and apply eligibility criteria for health-related social protection programs. And this links a little bit to the 4th priority, which was concerned the extent of fraud and abuse in health-related social protection programs. And we heard directly from policymakers that they were concerned about the extent of fraud and abuse in systems of social protection. Sometimes they termed it, framed it in terms of their own personal concerns, but also it was frequently a concern in terms of how do we sell this to the general populace, how do we sell this to other policymakers. And then finally, and again, actually, this had some connections to points 3 and 4 here, they were interested in the long-term effects of cash transfer programs on systems of social protection, and in particular, thinking about issues of dependency and whether systems of social protection and cash transfers could actually make people more dependent. So in the third phase of this research, we then synthesized the research needs coming from the reviews and the research needs coming from the policymakers into 31 distinct research questions. We did this by identifying health systems researchers who were familiar with social protection and health systems research. And we did this both by looking at who had been working on the reviews and who had been contributing to this literature, as well as a sort of open source solicitation accompanied by some screening of the people who volunteered. And we eventually invited 72 participants to participate in this process, of which 30 did. And again, there were a couple of stages here. In the first stage, the participants refined the questions so they could collaborate on this online platform called CoDigital, and that allowed them to tweak the questions, to make comments and suggestions on the questions. We then took those suggestions and came up with a refined and final list of 31 questions. And then we again used the CoDigital online platform to prioritize. And this was done through presenting the participants with pairs of questions. And on each pair of questions, they had to say which was the higher priority of those two questions. And as they were doing this, we asked them to think about 3 different prioritization criteria on the bottom right of your screen. Firstly, the potential benefit or impact of addressing that research question. Secondly, the tractability of the question or the feasibility of answering it. And thirdly, the extent to which answering that question would really benefit the poor and marginalized populations. This slide also shows you the top ranked research questions. Firstly, how can social protection programs for health be designed and implemented to ensure sustainability and scalability in low and middle income countries? So that's obviously a very broad question, but I think it sort of reflects an emphasis on the fact that we really need to take programs around social protection to scale, and that there had been a lot of interesting research around small scale initiatives, but had not been fully scaled up. Secondly, a desire to understand the contextual factors that influence the effectiveness of conditional and unconditional cash transfer schemes. Thirdly, how can various social protection initiatives be best integrated or harmonized across sectors? Excuse me. You remember that was one of the questions that came from policymakers. And then fourthly, how cost effective are conditional cash transfer programs compared to supply-side interventions? So this was one of the questions that came out of the reviews, but didn't sort of float to the top in terms of the reviews. But when we came to ranking it, people were very interested to understand the relative cost effectiveness of investing in conditional cash transfer programs vis-a-vis investing in strengthening infrastructure or expanding the geographical accessibility of health services. And the percentages here just show the number of times that this question won out over another question. So I think this is my final slide. And I just wanted to sort of conclude by raising a few discussion points before I hand it over to Mark and Marco. Firstly, I think it's very clear that the existing health policy and systems research literature on social protection is highly focused on conditional cash transfers, really to the neglect of other forms of social protection and how they may interact with health and health systems. In terms of the kind of evidence that policymakers were asking for, their focus was really not on conditional cash transfers, or at least not as a sort of primary or predominant area in which they needed evidence. They were much more focused on issues around design, implementation, scalability, sustainability, and how context affected all this. It didn't actually rise to the top 5 in the final exercise, or I think it didn't rise to the top 4. I think the previous slide I only got to the top 4 questions. But it was notable that several of the questions and what ended up being fairly highly ranked was around a focus on social protection in fragile and conflict-affected states. And I would note that probably amongst the panelists here today, none of us are particularly well equipped to pick up on this particular focus. Another thing that we observed is that, obviously, and as I started out by saying, social protection takes a variety of different forms, from sickness benefits, maternity benefits, pensions, and the health literature rarely unpacks those different forms of social protection and how they interact with and engage with health. And then finally, I guess this is sort of reflecting again on the initial impetus for doing this work. It seems to us that the SDGs, in essence, have quite a strong focus on the connection across different goals. And then there seems to be apparently a sort of relatively strong connection between SDG 1 around alleviating poverty and SDG 3 around improving people's health and well-being. And we're hoping that they really do provide a spur to expansion of research about the links between social protection and health. And I think that's all I have to say for right now, and I should hand back to Zubin for the next segment of this webinar.
Thank you, Sarah, for that extremely interesting presentation that then sets the stage for the next part of our webinar. And what I'd like to do is I'd like to invite Dr. Mark Blecher to first reflect on what he's heard and how this links with his experiences working with the National Treasury in South Africa as a policymaker. And after about 7 minutes of reflections from Dr. Blecher, similarly, we then invite Marco to give his reflections before we then open it to the audience. So, Mark, the floor is yours.
Thank you very much, Zubin. Greetings to everybody, to all the people who are connected to the webinar. Thank you to Sarah for inviting us to participate, and congratulations to the authors, particularly the authors who are also connected here for what's a very interesting paper, I think, in an interesting area. I'll talk a little bit about some of our experience in South Africa. If I'm speaking too quickly, just let me know. So South Africa is quite a large social protection system, mainly in the form of an unconditional social grant or cash transfer, which covers 17 million beneficiaries, including over 12 million children. It costs us about 160 billion rand, which is equivalent to about 3.2% of GDP a year. We also have a fairly large public health system costing around 200 billion rand per year, which is around 4% of GDP. Also a number of other areas of support within what we call the social wage, including free education, some free basic services in the poorest homes, such as water and electricity, and then an expanded public works program. Despite all of these, the country has fairly significant poverty levels and a very high Gini coefficient. Now, so we have this fairly large social protection program covering 17 million people with some evidence of positive effect or effectiveness on health and health outcomes. So particularly on lower rates of child poverty, higher expenditure by households on food, and lower levels of malnutrition, some evidence of increased weight for height ratios, particularly in girls. UNICEF studies talk about drastically improved school enrollment, because kids who are coming from very poor families often drop out of school, and also better attendance in school. And seems to be quite a strong linkage in our country between income and education. Some evidence of protection against HIV, and there's this literature in South Africa about conditional versus non-conditional cash transfers pertaining to HIV. And also some evidence of increasing employment in households. So that, for example, if an old age pensioner gets a grant, then sometimes the work age children of that pensioner will have some cash to be able to travel to go and job seek. And so there have been various studies which have looked at this effect. But despite all of this work, I think our level of certainty around the effects of this quite large social grant program on health are perhaps not as strong as they might be for many other health interventions, and also the actual size of the effects and the confidence limits around the effect are perhaps less strong than on some other health interventions, and it would be good to have further work on this in our context. Moving on to economic evaluation, this is an area that's very relevant to ministries of finance, which often find it very difficult to find common metrics to compare interventions across sectors. So whereas, for example, cost effectiveness analysis is widely used in the health sector, we find often in the social protection sector these interventions are used in our country much less frequently, and it's often much more difficult to compare interventions. And this does seem to be an area which merits research, partly in this with respect to how to better compare very different interventions across different sectors. Just as one kind of anecdote of this, in the last 5 years, social protection expenditure, social grant expenditure in our country has grown faster than health expenditure. And sometimes people from the health sector say, well, why are we being disadvantaged? Why is social protection expenditure growing faster than our budgets? But what is the methodological basis by which we make these decisions and this kind of prioritization? I think more research work in that area would be interesting. Michelle Remy in London has done some interesting work about how we often make budget decisions based on analyses of particular sectors, but our interventions like gender-based violence or some of the other HIV social interventions show greater effect if one has methodologies which cross sectors, which is quite new work because we often don't do that. On the area of conditionalization, which Sarah referred to, Bolsa Familiar in Brazil, for example, and others are often conditionalized. In South Africa, our transfers are not conditional. There's a literature about conditional versus non-conditional transfers. Ours are not. And some research on whether there would be benefit on linking health behavior, such as attending at a childcare clinic with one's clinic card should be incentivized in that kind of way. We spend a lot on social assistance, and I think that better research might help us in focusing the spending better. For example, we currently give a child support grant for children up to 18 years, but it's a very low-level grant, so it's below the food poverty line. Would it be better from a point of view of nutrition to focus on a younger age group, but to give a larger grant is, for example, an interesting question. In the literature around social grants, there's quite a lot of evidence suggesting that we should universalize social grants. On the other hand, the bank and various other parties suggest that we should go in the opposite direction. Rather than universalizing, we should focus more on greatest need. So which of those would be better from a health perspective? In South Africa, we have quite a large Pillar 1 social assistance system as opposed to a private Pillar 3 system, but almost no Pillar 2 contributory systems. Would progress in that regard be better for the poorest of the poor, or should we be expanding our Pillar 1 systems? Efficiency considerations are quite interesting with respect to the different programs. For example, our social grant program has got administrative costs of around 3% of the program, whereas some of our nutritional programs run by our National Department of Social Development have administration costs as high as 50%. Some of the more hands-on supply side programs can be much more expensive from an administrative point of view. And then we are currently facing questions around linkages between an emerging national health insurance program and social security programs. So, for example, should our road accident fund benefits pertaining to health and our compensation benefits through health be redirected through our national health insurance program? And should the health insurance program itself become part of a broader social security insurance program? Thank you very much. Those are the few observations that I wanted to make at this point. Thank you.
Thank you, Mark, for those observations. So I see a lot of questions around issues of allocations across sectors, comparable metrics, the more well-debated issues around conditional versus unconditional grants, as well as issues around targeting are some of the areas you brought up in your observations. I'd like to go on to invite Marco to now give his observations on this based on his experience working extensively in Latin America and both within development agencies, but also as a researcher. So wearing both hats. Marco, please do go ahead and give your reflections on this.
Yeah, good day to everybody, and thanks for inviting me in this seminar. I also want to congratulate the authors before starting with my remarks that revolve initially about the fact that the overwhelming majority of the literature and evidence is on cash transfers. 20 years ago, when conditional cash transfers started in Latin America, extreme poverty was much more prevalent than it is today. These programs replaced a multitude of inefficient programs that were small in magnitude, and they were characterized by things that didn't exist before, like very efficient management information systems, and also by impact evaluations. These impact evaluations have produced data that have driven a lot of research afterward, and this is why the majority of the reviews that were found by the authors were about conditional cash transfers. We learned a lot from these over 20 years on how to design and implement cash transfers in general, but we surely didn't learn everything. And one of the problems was that many of these programs were expanded without, in parallel, expanding the supply and, in particular, the quality of health care for the beneficiaries. This means that some of the health objectives were not achieved, maybe not because the programs were not well designed, but because they were not accompanied by the expansion of health care. I would like then to make my first point for people to maybe memorize, which is that we need to know much more about the quality and what is the best way to organize health care for the beneficiaries of social protection systems, who very often live in remote areas. They belong to indigenous minorities, and much more would need to be known about how to supply health care for these groups in relation to the provision of cash transfers. Now, 20 years later, where are we now? Extreme poverty is lower in many regions in the world, and this is reflected also in the Sustainable Development Goals. The Sustainable Development Goals explicitly have targets on non-communicable chronic diseases and mental health, etc. This means that in many countries, also the priorities in health care for the poorest populations are shifting, and there is a bit less of emphasis on maternal and infant health and mortality. Also, this remains very important, but there is a growing importance of chronic diseases. And so some countries are starting to think on how they can tweak cash transfer programs to address this. For example, in the Bahamas, a cash transfer program was designed to address the problem of overweight and obesity among teenagers. And in Peru, we had discussions with the government on how to use cash transfers to address overweight in children, in young children. This is an important field of research. There is not a lot of evidence on this yet, and it has ties with behavioral sciences and how to use nudges to achieve these goals. The other consequence of broadening the focus of the development goals is that it opens up entirely new areas of research for low and middle income countries. And at the Inter-American Development Bank, we are dedicating resources in recent years to study the problem of aging of the population, and in particular to the issue of functional dependency and the supply of long-term care and support services. Developing regions are not old yet relative to richer countries, but they are aging at a very fast speed. And they are approaching the stage that richer countries were at when they started designing their long-term care programs and institutions. There are very important questions that come to mind, such as what is the effect of providing these long-term care and support services on the overall cost of health care? What is the effect on the quality of the health of the elderly? These are probably not captured in the review that was done for this paper, because there is not a lot of literature on in developing countries on these topics. And very often this is also not in the radar of policymakers. For example, in our region, the only country that has a formal long-term care system is Uruguay, and is one of the countries that are more advanced in the demographic transition. To summarize, three areas where I would find research very useful for our work is the first point I made was the quality of health care for beneficiaries of social protection. The second point was how to tweak the programs to address chronic diseases. And the third point was branching out to entirely new areas such as long-term care and support services. Thank you.
So thank you, Marco, for that very comprehensive reflection. What I found interesting was you began by discussing, taking us almost through the epidemiological transition, beginning with the challenge of why some of the initial demand-side financing programs did not achieve their goals because of lack of adequate improvements on the supply side, a lack of attention to quality, and then going on to discuss the kinds of challenges that countries are facing as we go through the epidemiological demographic transition in terms of chronic care, long-term care, and dependency, and the implications this has for the links between social protection and health systems. So thank you to both of you for your reflections. I just had a couple of reflections to make before I open this up for the audience's participation, and I'm already getting plenty of questions in the chat box, and please be assured that these will be summarized and provided to our panelists to discuss. So one reflection I had was that while both SDG target 1.3 and 3.8 talk of universality in terms of social protection and universality in terms of health coverage, the changing pattern of employment in the developed world, as well as the fact that in the developing world, labor market interventions and social insurance programs are so challenging given the extent of informality and the kinds of issues this brings up. The second, which I wanted to reflect on the presentation that Sarah made, is to contrast between research review and policymaker priorities. Research reviews are much more concerned about effects, outcomes, and pathways, particularly of conditional cash transfers and unconditional cash transfers. And we see policymakers, given their job profile, unsurprisingly much more concerned about processes. The other thing is, again, this links back to universal social protection. We see from the policymaker perspective and looking at the paper as well, there's a great concern with eligibility criteria, which again then contrasts with the universality agenda of the SDGs and UHC. And then one point which I think came out in Marco's reflection very well was that we have a broad sweep of questions and concerns that greatly vary with the economic structure of the country and socioeconomic indicators, and that social protection measures require very different levels of infrastructure and regulation. So an unconditional cash transfer requires much less ongoing information management, the kinds of health information system tools that you need, the kinds of other regulatory apparatus you need, then putting in a social health insurance program. And this also fits in well with what Sarah brought up about the lack of literature really unpacking social protection across different interventions, and also the questions related to what would really be appropriate in fragile states and conflict-affected settings. So that's I'd like to now bring in questions, and I'd like to put some of these questions to the panelists. The first question we have is from Raja Lakshmi in India, who has said, how did health equity appear as a priority research area in both the reviews and policymaker discussions? And I'd add a couple of other questions to this. What do you think are some of the reasons for the very few papers that looking at the link between health systems and systems of social protection, particularly in low and middle income countries? Sarah?
Thank you, Zubin. Raja Lakshmi, there was a question which came out of the reviews around equity, and in particular, the impact of social protection initiatives on health equity outcomes and equitable access to quality healthcare services for poor and marginalized populations. So there was clearly some concern about it. I think that, and it came out, I think it was sort of number 7 in the final ranking. So it wasn't something that was entirely neglected. I sense that many people, when they were talking, the policymakers, when they were responding about systems of social protection, sort of almost thought that it was automatic, that they had linkages particularly to more vulnerable and lower income populations. So maybe it was implicit in some of the questions and not explicit. But I think that Mark raised some really important sort of follow-on issues there, particularly about the distinctions between targeting and universal approaches to social protection, and whether we should really be targeting on the most vulnerable or thinking about them as more universal, broad approaches, and how that ties into ability to politically sustain some of these systems over time. I'm not really sure how to answer your question, Zubin, about why isn't there more literature in this space? And I should first of all say that I don't see myself as an expert around in particular around the connections between social protection and health. I think that perhaps Marco and Mark may be better placed to talk about some of that. I guess it probably reflects the fact that many of us work to a considerable degree in silos. I work in a school of public health. We're fundamentally concerned about, different interventions that are public health related. And I think that broadly speaking, one of the things that the SDGs have done is to prompt us more to think about how different disciplines should need to be working more together. And I think in this domain, we really need to be working more with economists and others who are thinking about systems of social protection, as well as how different sectors work together, which was obviously the theme of the last webinar. Thank you.
Thank you. So going back to one other question, what do you think are some of the conceptual and methodological challenges to this kind of work? I mean, going beyond the kind of challenges of investigating the links between social protection and health systems in terms of methods that can be used for this, as well as any conceptual challenges that you see, as well as practical challenges to actually carrying out work across sectors.
Are you directing that to me, or perhaps you'd like to move on to Mark with some of these challenging questions?
Yeah, Marco could respond to that as well, given that he's also a researcher.
I can take it on, but I will actually deflect the question to a similar one, which shows the one of why there is not more research on this. I think it's related to having two disciplines that speak different languages. The literature on social protection that has expanded around cash transfers was led by social protection or economists, and that were originally poverty economists, and more than by scholars of health economics or public health. And the methodology and also the way in which papers are organized in different journals are really different. So I can take a paper and I write it as a poverty economist and I send it to a public health journal, and very likely it will be rejected. The methods are different, the ways in which the research is organized are different, and there is a bit of a lack of communication in between the two disciplines. The same happens within the governments. Sometimes these programs are seen as programs of Ministry of Social Development, and when the health ministry needs to do something, sometimes they see it as an additional burden on them to collect more information, adapt services for a specific population. And some countries have managed these to create a synergy, but in many other countries, the health ministry has other priorities. It finds it easier maybe to build hospitals than to expand the primary level of healthcare in the more remote areas. And therefore, there is a disconnect also within the governments between social development and health. And all this probably justifies the relatively little literature on the health part of conditional cash transfers.
So thank you so much for that response. Now, building on that, and Mark, I think you could come in here. What do you think needs to be done to enable the research that is carried out to actually inform policy design in terms of engagement? You work within the ministry and within the treasury. So what would you see as what needs to be done to enable this research to actually inform policy in terms of the types of research products, in terms of research priorities? How best do you think this can be done to help address your day-to-day needs and break these silos which Marco has so well brought out?
We can't hear you, Mark. I think you might need to unmute yourself.
Okay, thank you for that. I do think it's important for researchers, where possible, to work closely with policymakers in formulating their key questions, because their research is much more likely to be implemented in that case. I mean, I think, for example, in some of the development of social assistance in our country, for example, and the child support grant, for example, was increased from the age of 7 to the age of 18 over many years, without any real academic studies, or very few academic studies, and none, I think, on the linkage to health. And now we have a very large social expenditure, and which makes it difficult to expand. And we have a significant uncovered group. So an uncovered group, for example, that we face now is pregnant women. So the child support grant in our country starts, once the child is born. The mother in pregnancy is not covered. And we have quite a lot of low birth weight children. And we're starting to get that linkage from researchers now, pointing out the importance of this uncovered group. But a lot of the earlier decisions that were made without a very strong research base. So these are social expenditures are often very large areas of spending. If you look in Europe, I mean, social expenditure can be the single largest area of government spending, as high as 30% of GDP. So I think, there are important research questions which there's a lot of benefit for policymakers and researchers to work more closely together in this area.
Thanks so much, Mark. Now, coming to some questions I'm just receiving in the chat box. A question from Eric Nambeda from Kenya. Is there any evidence, he asked, from research linking the quality of universal social protection and the expansion of healthcare infrastructure in LMICs? Another question which has come from Not Lonrot. Apologies, I hope I'm pronouncing your name correctly. He asks why research on paid sick leave or sickness insurance has not been prioritized. And a second part of his question about coverage of paid sick leave globally. He mentions that ILO has mapped the status of national policies, but not coverage. Do we have any way of knowing who is covered by paid sick leave? These two questions, I put these to the panelists.
Well, I can start taking advantage of the silence so I can take the question that I better know how to respond. I think that when we talk about sick leave or maternity leave benefits, we are talking about formal employees. And in many countries, the formal employees are a very small minority. And among the beneficiaries of the social assistance programs, there are basically no formal employees. Therefore, in a country like Uruguay, in Latin America, for example, these are very important programs. But if we take a country like Honduras or Haiti, for example, there is absolutely no real coverage given by social protection for formal employees. And this is also related to the point that Mark was making of the 30% of expenditure in social, let's say social expenditure. A lot of this is actually social expenditure for the vulnerable class maybe, but not for the poorest. And for example, a lot will be in contributory pensions. In Brazil, this is between 10 and 15% of GDP and growing fast. But when we talk about social assistance, very often we're talking about 1 or 2% of GDP. And this is not a lot of money for these programs, and a lot of it is spent on cash transfers. And we have learned now that cash transfers are not enough on their own to produce the change. For example, we need more social workers to facilitate change in poor families. And this is a very limited service. So there is a disproportion of expenditure in many countries towards the formal sector.
Thank you. Anybody responding to the question on research linking quality of social protection and expansion of healthcare infrastructure? If not, we can move on.
I can comment briefly, Zubin. So I guess, Eric, I'm not entirely following the kind of linkages that you anticipate would be there, and why universal social protection may or may not lead to an expansion of healthcare infrastructure. So maybe if you want to, add to your question and explain that might be helpful. But I guess the point I was going to make would be a slightly broader one, which is from what we were seeing in the literature, frequently the health-related literature around social protection is focused on particular schemes rather than a broad system of social protection and understanding how the different elements of a system of social protection fit together. So I think that is also problematic in terms of answering the question, because I don't see much in the literature around health that's looking broadly at systems of social protection in their totality. They're looking at a conditional cash transfer scheme and how that works, rather than thinking about the multiplicity of schemes and programs that come together to form a broad system.
Thanks. I think linked to this, the fact that most social protection in low and middle income countries, particularly in lower middle income countries, has focused on safety nets rather than the first two mechanisms. There's a question from Divya Ravindranath on how do we understand social protection in the context of informal work, which employs a large share of people in countries like India, and what are the big challenges there? And I think this would be an important question given the kinds of large population that does live in countries dominated by a growing informal economy, even in the context of rapid economic growth. Would any of the panelists like to respond to that?
I think
Mark is answering, but he didn't unmute the microphone.
Okay, it's Mark. Maybe I can just try and say 2 points on that. I think firstly that's partly why our system of social assistance has grown far ahead of our contributory social insurance system, because we have such high levels of unemployment here. So that formal insurance, also as Marco said, is relatively low in many countries. In our small contributory systems like our unemployment insurance fund and our compensation fund, there have been various attempts to broaden the base of coverage to enroll additional groups of workers. There's been some successes in that, but I mean clearly in insurance systems, in enrolling the informal sector, this is often the most difficult parts of expanding social insurance.
Thanks so much. We have one more question from Nat Lonerot, who asked, should we anticipate that the vast majority of the workforce will remain in the informal sector within the SDG era? He's asked whether this is something that we should anticipate.
Well, I think probably the informality of employment is going to remain a very serious problem. One cannot think that in 10 years all the workers will be formal. The informal sector represents also an important part of the economy, also in some European high-income countries. So this is going to remain a reality. And part of the debate about universal income schemes or universal basic income in some countries, or the experiments, are also related to the will to reduce the negative incentives to remain in the informal sector. So the thinking is the following: if I create cash transfers, for example, or other schemes that benefit the poor and the informal only, I'm generating an incentive to remain in this group. This is an argument in which personally I don't believe very much, and I think that this is driven very often by some research papers that emphasize the significance of the impact more than the magnitude of the impact. So the magnitude is relatively small and the problem is not big, but it makes it to the headlines. And therefore, there is a whole debate about let's replace these programs with universal schemes that don't create any disincentive to formal employment. But as Mark said before, if you do this, then you are forced to lower the level of the benefit, and you probably spend all your budget in transfers, and very little will remain for all the complementary services that are needed to really achieve an impact. So that's why many people still argue in favor of targeting. This is a debate that is going to last for a long time, as well as the fact that informality will last for a long time.
Thanks so much. Do we have any more questions from the audience? If you do have questions, please type them into the chat box.
So Eric has come back and expanded, excuse me, on his previous question. And if I understand you correctly, Eric, I think it's connecting to what Marco was saying earlier. It was his first priority, the fact that often we don't know about the quality of care for people who are beneficiaries of systems of social protection. Or if we do, and then as you're suggesting that perhaps the quality is compromised, and this is affecting the overall effectiveness of the intervention. So if I understood Marco correctly, one of the things that he was suggesting we needed to understand better was how to improve the quality of health care services for people who are beneficiaries of social protection programs, such as the one you describe here.
I can comment on this. I cannot give a satisfactory answer, but I can point you towards some work that has been done. For example, when the conditional cash transfer was launched in Honduras at the beginning of the 2000s, the intervention was broken in different parts to a group only an improvement of supply I don't remember, probably healthcare and education was given, so only supply. To a group, only cash transfers, and to a group, the combination of both cash transfer and supply. That was exactly the type of research that allowed to answer Eric's question. Unfortunately, the implementation was difficult for different reasons. Cash transfers can be expanded relatively quickly, while the supply interventions take a long time to be effective. Sometimes, at the beginning of a supply intervention, you could have even worse service than if you were not doing any intervention, because maybe you are restructuring something, you are training, it takes time, and the evaluation is often carried out at the beginning. Now, when you fast forward many years later, if you want to study that, it's much more difficult to find data, micro data on the supply side interventions. We have a real lack of data on supply side intervention. So some work has been done somewhere in the world and you could search it, but it's not very satisfactory quality and it has not answered the question.
It's Mark. Can I come in on this question as well?
Sure, go ahead.
Zubin, just to point out that in South Africa, and this was one of the first steps of President Nelson Mandela when he became president, was to make maternal and child health services free. And it had an amazing effect in our country for making pregnancy care accessible. It's been one of the greatest achievements, I think, of the first decade of democracy in our country. In our latest national health insurance proposals, there's a strong proposal to make all health services free. Currently, revenue being generated through fees is around 4 billion rand. I think there are bigger questions about whether all services should be free, but that is certainly the direction our country is heading. But certainly the intervention that President Mandela put in place was very effective in our country. Thank you.
Thank you. We have one more follow-up question from Eric, who asks whether countries in LMICs are ready for universal social protection programs, and could one think that such countries are better off going for a targeted approach? This is, of course, a very contentious, much debated question, which we can discuss, but I'd like to get the panelists' reflection on this.
I can give you an example of a Latin American country for which we ran some simulations, and very, very basic, very simple idea. You transfer an extreme poverty line to everybody in the population. The cost would have been about 10% of GDP, and it could be higher in countries where GDP is lower. And therefore, the real issue is that if you do a universal scheme, you probably have given budget constraint to give a very low amount of transfer. And therefore, the trade-off will be, if you give a lower amount of transfer, are you really going to achieve your goals? If you think that this is a nudge, maybe you can achieve some goals. If you want to give a substantial contribution to nutrition in the families, probably you are not going to achieve that goal. So the trade-off is between magnitude of the transfer and the amount of the and the universality of the program. This for transfer. Then I will let somebody else answer about services.
So if we don't have any questions, what I'd like to do is ask each of the three of you to give some closing remarks regarding the webinar and your reflections on the questions that you've had. Sarah?
Sorry, I was having some difficulty there.
Sorry, I said since we don't have any more questions, I'd invite each of you to give closing remarks, the three of you.
Yes, sorry, Zubin, I was just trying to unmute myself and the mouse wasn't moving as I had hoped it would. Firstly, I'd really like to thank my co-panelists. As I said earlier, I don't feel that I'm an expert in this domain, and I think that their comments have really helped me understand a little bit better what some of the challenges are. I continue to feel, and I think, this webinar has reinforced this notion that social protection, as Mark was saying, is an area where we're seeing, significant amounts of money spent, and to ends which at least have health as one of the sort of outcomes that we may think is a realistic to hope that we get improvements in health from spending on social protection. And yet it seems to me that for various reasons that we've begun to explore in this webinar, these two domains around social protection and health have really not been researched in an integrated way or understood even, conceptualized in an integrated fashion. I think that, to be very honest, speaking for myself, I feel that I'm still figuring out the ways in which to best articulate the linkages here. And I think that the paper that we published is sort of barely scratching the surface in terms of what are the real research needs here, and how should health policy and systems researchers seek to prioritize their attention, both in terms of different forms of social protection, different kinds of questions that we could be addressing, whether they're to do with effectiveness or implementation processes or quality of care. So I think that the paper hopefully will be seen as a stimulation to more thought in this regard. I think one piece that, again, we've talked about a little bit in this webinar, but I don't think the paper gets into, is the question of why hasn't there been greater efforts to bring these two fields together, and greater efforts to ensure that the research that's done is sound, both from a sort of anti-poverty economics perspective, as well as from a sort of health service, health systems perspective. So I think that it's really a domain in which more thinking and more multidisciplinary, cross-disciplinary collaboration are needed. Thank you.
Thanks, Sarah. Mark?
Well, I just want to thank really everybody who's participated in this. I've just found this as a mode of communication really interesting. I mean, having comments coming in from Kenya and from India and from Portugal and from a whole lot of places, for me, has been really quite an eye-opener. So thank you for inviting me. I just found this a really interesting way, a new way to communicate. Thank you.
Thank you. And Marco?
Then maybe I will recommend to researchers to spend more time and resources on describing the supply side of interventions. That would be really helpful to document what was done on the health sector, in addition to explaining what the impacts of the social protection intervention were. And for policymakers in the health sector, probably I would recommend to bring together always social development, health, and also the Ministry of Finance whenever research questions are decided, when results are presented, because in the end, finance and economic ministries are very important in the decision-making process. Very often, nothing can be done in the sectors without the push from finance. Thanks to everybody, and thanks for the opportunity to participate in this webinar.
Thank you. Sarah, as you spoke, we just had one last question for you. Katerina asked the fact that the study found research questions from reviews not matching those proposed by policymakers. Could this be hindering implementation of social protection programs? Could you just give your quick thoughts on this, please?
Sure. And thank you, Katerina, for the question. So I guess I see this lack of overlap. And I should say for the other two domains, we also saw some lack of overlap, but I don't think it was as great, perhaps, as we're seeing here. I think it relates in good part to the fact that much of the literature in this domain is very much wound up in conditional cash transfers, whereas policymakers are obviously thinking about a broader array of social protection programs and interventions, and certainly not so narrowly focused on the conditional cash transfer scheme. So I think that's sort of explaining why there is the gap. In terms of whether or not this is hindering the implementation of social protection programs, I mean, I guess the lack of evidence in a number of different domains about how social protection programs can influence health and influence different types of health behaviors and health conditions, and the lack of evidence about the quality of services being provided under social protection, quality of health services being provided under social protection systems. All of that, collectively and taken together, just means that there's perhaps not the strength of evidence that policymakers ideally would need for decision making. But to say that it's actively hindering implementation of social protection, I don't have good examples off the top of my head, although maybe my co-panelists do. Thank you, Zubin.
So thank you to all the participants for joining us. Thank you to the 3 panelists. A recording of this will soon be available. And Sarah, could I please have the next slide? Just wanted to make one announcement. There is a call for papers, Health and the SDGs Intersectoral Action for Health, the special issue of Globalization and Health, and the deadline for abstracts for this is the 10th of December. So just a heads up to all interested researchers out there and encouraging you to actively submit for this. So thank you very much, and we've greatly enjoyed the session, and we hope that this area will be an important area for research in the HPSR community going forward. Thanks once again for joining us today. Bye-bye.
Thank you very much, and bye-bye, everyone. Thank you.